Today on Primary Care, chronic kidney disease, the reason why nearly 350,000 Americans are on dialysis.
Kidney disease is real, it's no joke. And there's a lot of people out here with kidney disease, and that's reality.
Chronic kidney disease. Ask members of the medical community and they will describe it as an epidemic. The main target, African Americans and other minorities. Hello, I'm Dr. Lonnie Joe, the weekly host of Primary Care. As a practicing physician in internal medicine, I see it all too often. Patients coming in with complications leading to kidney disease and eventually dialysis. Here to help us understand more about the seriousness of this disease is Dr. Valerie Dye. Dr. Dye is a nephrologist who treats patients with chronic kidney disease and end-stage renal disease. Dr. Dye, welcome to the show.
Thank you for having me.
Tell us a little bit more about these terms. We sort of use these terms interchangeably: end-stage renal disease, renal failure, renal insufficiency. Help us understand a little bit more about that.
Well, one of the things that happened, it was very confusing as to when people should refer patients to a nephrologist. So one of the things that happened, a staging system for kidney disease was developed so that everybody would speak the same language. For the most part, we stage kidney disease in 5 categories. Stage 1 would be called normal kidney function, and that's anything that gives you an estimated percentage kidney function of 90% or higher. Stage 2 would place you in a range of 70% to about 89% kidney function. Stage 3 happens to be one of the biggest ranges that we have, and those are people whose kidney function range is anywhere from 30% up to about 60-65%. By the time you get to stage 4 chronic kidney disease, your kidneys are working anywhere between 15 to 29%, and at that time many people will refer their patients to see a nephrologist. What we refer to as end-stage renal disease that refers to people whose kidney function is less than 15%, and most of those people need some form of renal replacement therapy.
Now, basically, there are some disease states that contribute to the development of kidney disease or renal failure. Talk a little bit about the comorbid disease states that we see that actually lead our patients down that road to dialysis.
The majority of the patients that I see that end up on dialysis are patients who have either diabetes, hypertension, or a combination of the two. Unfortunately, because there's such a high incidence of obesity in our community, many of our patients have high blood pressure, diabetes, and on occasion you do see patients who have other diseases, but I think that would be a little too in-depth to discuss here.
So basically, 2 main disease states that we find in the African American community and the community as a whole, diabetes and hypertension, are contributors to the development of kidney disease.
Most definitely. One of the things that I do like to encourage my patients to do is to do everything they possibly can to control their blood pressure and to control their diabetes. Many people don't give any consideration to what can happen if you don't take your blood pressure medications, because it is a silent killer. Most times when people's blood pressure is uncontrolled, they don't have any symptoms. Unfortunately, sometimes those symptoms can be a heart attack or a stroke. So I like to encourage people to take their medications even if they feel okay, and the same thing with the blood sugars.
Talk a little bit about how indolent the development of renal disease can be. We see patients walking in all the time who, for whatever reason, has not had an examination or a blood checked or anything, and all of a sudden you say, oh my God, your kidneys are fried, and they feel fine. Talk a little bit about that presentation of patients.
Well, unfortunately, that happens all too commonly. Your kidneys actually do a very, very good job of trying to maintain what we call homeostasis. They try to maintain your volume status and to keep good things that you need, like vitamins and minerals. Unfortunately, your kidneys will work themselves to death to do their job. And the really sad thing about dialysis or end-stage kidney disease is it doesn't really have any specific symptoms. I do have patients who will come in with just kind of really vague, non-specific symptoms. Oh, I've lost my appetite. I feel tired. My get up and go got up and went. Many times people will tend to shy away from eating things that they normally used to eat, like meat, chicken, fish, that kind of thing. And they'll eat more soups, more vegetables, more fruit, because it's easier for your body to break down fruit and vegetable products than it is to break down animal products. So usually by this time, the only conversation I can have with my patients is how we're going to deal with the need for dialysis.
And that's a devastating subject, I'm sure.
Yes, it is.
Now, I know that you've had some personal experiences with this. Your father was a renal dialysis patient.
Yes, he was. My father actually, he was a very good patient, but you know, sometimes even when you do everything that you possibly can, you can still end up in the same situation where you do need renal replacement therapy. When I started my training as a nephrology fellow, my father was informed that he would need to do dialysis. Thankfully, there are different ways to do dialysis, and he opted to do one that was what we call painless dialysis, which is called peritoneal dialysis. That involves putting a catheter in the belly and using basically an IV bag of fluid to do exchanges and actually get rid of toxins from your system. He did very well with that for about a year, but after a while we ran into problems and he switched over to hemodialysis. He did very well with that until 5 years later when he passed away from congestive heart failure. But I'm very happy that we had that as an option because he would have passed away a lot sooner if we didn't.
A good medical experience for your dad.
Definitely, definitely.
So often we have to deal with the family involvement in terms of when the access is placed and all the complications associated with this. Are we getting the right kind of response that we need to from patients and their families? Are they buying into this disease state to the degree that we're making the kind of progress?
It's still very difficult. Unfortunately, because there are no real symptoms for end-stage renal disease, people have a tendency to put off the placement of the access, which would be things like an AV fistula or a graft, or in extreme cases and in emergencies, we use catheters, which allow us to do dialysis very quickly. We try our best to discourage people from putting off planning for renal replacement therapy because we don't want to do things in an emergency situation. What we're trying to do now, between most of the kidney doctors that are in practice now and the National Kidney Foundation, we try to prepare people for dialysis so they don't do what we call a crash land into dialysis. We prefer to have patients go and get their access placed, and once it's placed and developed, we can just wait and see when they develop symptoms.
Patient education.
Definitely.
And a calendar that gives them some reasonable expectations in the treatment of this disease. Very interesting. We're going to go to a break. Coming up next, you'll hear from a patient of Dr. Dye's who got an extreme wake-up call when both of his kidneys suddenly failed.
So they say it's a man's world? I don't see anybody's name on it.
While they were doing their thing, we slowly changed ours.
Today, women can do anything men can do. And there's one thing we're even better at.
Body language can tell you all sorts of things. Like someone is having a stroke. Know the sudden signs. Learn fast. Face drooping, arm weakness, speech difficulty. Time to call 911 and get them to a hospital immediately. Learn the body language and spot a stroke fast.
Since 1918, the Detroit Medical Society has been there for physicians, patients, and the community. We were there then, and we're here now. The Detroit Medical Society, here for you.
Welcome back. Kidney disease takes the lives of over 80,000 people each year. Before getting his kidney transplant, Alvin Hooton came close to being one of them.
Kidney disease is real. It's no joke. And there's a lot of people out here with kidney disease. And that's reality. I was diagnosed with diabetes in 1984. That's when I made a big mistake because 31 flavors. I said I just want to eat 31 flavors. And then I pursued it. And when I walked out the store, I noticed everything started getting blurry. And 2 days later, I ended up in a hospital with a blood sugar of 750. That's when I officially pronounced I was diabetic. Hypertension from childhood, I've been knowing about that since childhood. My doctor's been telling me that you have high blood pressure, that you need to start taking blood pressure medicine. And actually, I basically ignored it because to me, I felt fine. I found out I was having kidney problems when I had my first knee replacement. I used to be pretty close to 500 pounds at one time because I wasn't eating right. And I had a serious eating habit, so I loved to eat. When I had my first knee replacement, the doctor came to me and was telling me about something about your creatinine levels is real low. It's a good possible chance you're going to, having kidney problems. You need to take care of that issue, keep your blood pressure down. She said, if you don't take care of your creatinine levels, you're going to end up, on dialysis. And sure enough, one day I was walking down the hallway, almost had congestive heart failure, a lot of fluid around my heart. I couldn't barely walk 3 steps because I had a lot of fluid around my heart. I was admitted to the hospital, and that's when I found out my kidneys went out. When I first got on dialysis, I had to be on the machine like 6-7 hours a day for 3 days a week. That's being on the machine to be kept alive for half a week. That was traumatic. It took a lot for me to accept that. Because like my whole lifestyle changed. I no longer could work. I no longer do the things I used to do to have fun. It's just my whole life just slipped away. Number one, I made a decision that I wanted to live and be healthy. And it took a process. I went to a seminar to find out about getting on a donor list, which, number one, I did not qualify to be on the transplant list. Because number one, I wasn't eating healthy. My numbers was off. I was overweight. And I had all these medical issues. So I had to turn that around. And I did it. I lost 240 pounds. And as I was losing weight and the joint replacements, the damage I did to my body for ignoring my eating problem, not taking my medicine, not taking care of my blood pressure, not taking care of my diabetes, the problems started occurring. The joint replacements, I had neuropathy, So I had to undo the damage my illness was causing my body to even be considered to be on the donor list. So it was all the determination was up to me. How badly do I want a kidney? And so I took it to the extreme. I decided I want to live. I got my kidney in September, and I feel better than I did when I was going to high school. It took me a while to get used to my body being normal. I ain't never had normal blood pressure in my life, And it's like, I feel it's weird, like I'm healthy. I can move around. I can bend down. I can bend my toes, bend down and tie my shoes. I can cross my legs. I got more energy. I'm more active. But I've never been that way before,
Now, Dr. Dye, Mr. Hooton is a success story that almost wasn't. Very serious set of circumstances and potential complications.
Well, Mr. Hooton was one of my special patients. We had some challenges with compliance and coming to dialysis treatments as we should, but he decided to become an active participant in his health care, and he has turned the corner, and he is one of my star patients. He actually goes back to the dialysis centers to encourage other patients to get on the transplant list and to do what they need to do to stay healthy.
So presenting with all of the complications that we see on the primary care side every single day turns out to be a success story. Fortunate to have a great doctor like yourself, but also fortunate to be able to take care of or take advantage of all of the modern advances that we are able to assist patients with who have renal disease. How has the patient population in the African American community done as a whole in terms of renal failure? Are we getting the care that we need?
Well, because there's such a focus on the different stages of chronic kidney disease at this time, many patients are being referred to nephrologists much earlier in the process of their disease. If they come earlier in the disease process, we have a better chance of slowing down the progression of kidney disease and hopefully halting it in its tracks. One of the things that we do like to encourage our patients, particularly if they're diabetic and they have what we call proteinuria or protein in their urine, I am very adamant about encouraging the patients to eat more plants, to eat more vegetables, fruits, beans, and things of that nature, because it's much easier for your body to process vegetable proteins as opposed to animal proteins.
So here again, more patient education, lifestyle choices, lifestyle changes.
Definitely, and doing that in conjunction with the physician who's supporting you in doing those things.
Are there any particular things that you warn the patients to avoid in terms of daily intake, or any medications or particular medication, a class of medications that these patients should be aware of?
Now, most patients who have any problems with their kidney function, I try to discourage them from using any over-the-counter pain medication if possible. We run into a lot of problems with what we call acute kidney injury with medications like naproxen, Aleve, Motrin, things of that nature, because they can cause problems with the blood pressure in the kidney. One of the other things that I talk to patients about as their kidney function declines, I try to get them to steer clear of foods that are high in potassium, because potassium-rich foods, if you can't get rid of the potassium from your kidneys, it actually can accumulate in your body and make your heart stop, which can lead to your death. So those are things that we definitely talk to patients about. We like to refer them to renal dietitians so they can get an idea of things that they can eat and things that they should avoid.
Nobody likes a renal diet, but they certainly can adjust and do some things that can improve the choices that they make in terms of eating out, preparing foods at home, not unlike a lot of things that we approach patients in terms of education and other disease states, diabetes in particular. Here again, the patients have to buy into the treatment of their disease. What are we seeing in terms of patients and complications with dialysis?
Well, most of the time the complications that I see are usually related to catheters. Most times when we try to get patients ready for dialysis, they either have something called an arteriovenous fistula, which is a fancy way of saying connecting an artery to a vein to actually develop an access that we can use to do dialysis. Now, sometimes we can't do that for patients and they have a graft, but these are things that are within your body and they don't have a high risk of getting infected. Unfortunately, a lot of people are afraid of the idea of making preparations for dialysis, so we end up having to put catheters into the patients, and as you know, anything that goes into the skin as an IV, be it a big or small IV, it acts as a highway for any type of infection to get access to the blood system. And this can lead to people getting very serious infections where they lead up in the intensive care unit and sometimes leading to their death.
Yes, we see this all too often, especially patients presenting to the emergency room with all the complications of infections, and the access is the focus. Here again, I would assume that the rub comes with a lot of these patients in getting them prepared for dialysis with the assumption that looking at your numbers, eventually that's what's going to have to happen in order to continue your treatment. And patients can pose a little resistance to that.
Yes, they can. But I find that if you try to meet people where they are and you're consistently telling them the same things, eventually people will make that decision and proceed and make decisions that are best for them. In addition, by the time the patients do get to the dialysis centers, we have a very active program of aggressively trying to make sure that we get the catheters out. Some of the dialysis centers call it cathaway, and we like to get rid of those catheters in 90 days from when they start dialysis. That has actually led to a very big drop in the incidence of infections and complications related to catheters. So we're very proud of that.
That's great. We're making progress.
Definitely.
We'll go to a break. Primary care will return in a moment right after this break.
Today's the day to make a difference.
To help people live free from heart disease and stroke.
That's why the American Heart Association
was there to get smoking out of our restaurants, bars, and airplanes.
And showed millions of Americans how to use CPR to save a life.
Together, we taught hospitals how to better handle stroke emergencies.
Today is the day to get involved.
Join the American Heart Association's fight against heart disease and stroke.
This is where heart doctors throughout the Midwest are bringing their toughest cases, where specialists from around the world come to learn, where patients who couldn't be saved before are being saved. The all-new state-of-the-heart DMC Heart Hospital. This is Detroit, rising, medicine advancing, the future unfolding. The new DMC Heart Hospital. This changes everything.
Welcome back to Primary Care. Dr. Dye, we're seeing younger adults in trouble with their kidneys. Health conscious, supplements, health food store, internet, pill books. What's the reason or contributing factors to the younger population in this country heading toward renal failure and eventually dialysis?
Well, unfortunately, I sound like a broken record. I'm saying the same things over and over again. What's happening now, we're seeing a lot of the adult diseases occurring in younger and younger children. There was a time when type 2 diabetes was called adult onset diabetes because that's when you saw it. Unfortunately, just within my practice career, we've had to change the terminology because we're now seeing 10-year-olds coming in with type 2 diabetes. And all of it goes back to lifestyle, dietary choices, lack of exercise, and the development of these problems. We have children that have hypertension. We have children with lipid disorders, and they're being put on Lipitor and various cholesterol-lowering medications. We really do need to make a serious overhaul in how we're approaching diet and lifestyle in our country.
And patient education is in the forefront of that again.
Yet again.
What do you see some of the socioeconomic factors that affect this population that basically needs more education instead of treatment?
Well, unfortunately, there's a limited number of places where these people can shop. There's a lack of fresh food in many areas. If you ride around Detroit, many times you see lots and lots of fast food restaurants, but you can't find a place where you can get fresh fruits and vegetables.
The old food deserts.
Exactly. I'm happy to see that there are some businesses that are coming back to the city and providing avenues for people to obtain fresh, healthy food, but we've got a long way to go.
And I think everybody is glad to see the refocusing of these kinds of resources. Until then, though, I think that we have to remain vigilant as physicians and providers in terms of advising this patient population correctly, and hopefully we can see a real change in the outcomes in the future. Let's move forward a little bit here. Tell me about what's coming down the pike. You and I talked briefly earlier about what the needs would be in terms, or what we would like to see happen in terms of early diagnosis of kidney disease and markers of these kinds of inflammation in the kidney. Tell us about some of those things that are coming.
Well, there are quite a few people who are doing research to find better markers of kidney disease earlier on. We haven't quite come up with what we'd like to call a kidney troponin, but people are working very diligently about that. One of the other things that is very exciting, there are actually more programs that are developed now for home hemodialysis, which allows people to do dialysis more frequently, which is more like your regular kidney function because your kidneys work 24 hours a day. In addition, I'm very excited to see that they are working on wearable dialysis devices, and I do hope that in my lifetime we get to the point where we can actually clone kidneys and just provide people with new ones when they're no longer working well.
How about that? The kidney transplant or the organ donation conversation always comes up, and there's a great deal of fear in African American community sometime of who gets what or who is in line to get what in terms of organ transplant. But we've seemed to come a long way in terms of helping people get organs in the renal disease end of this business better than some of the others. Do you think that we're making the progress that we should? Are we really catching up with the rest of the population of this country?
We're trying. There are lots of organ donation drives and stem cell drives that go on at various churches and things because even though African Americans are overrepresented in terms of the people who are struck with end-stage renal disease, there's a very small pool of actual African American donors. And I'd like to try to encourage people, if you possibly can, please donate your organs. Every major world religion is in agreement that organ transplantation is not in violation of any religious principles, and it will really go a long way to help people,
Very good. All you have to do is sign up with the Secretary of State, and
Exactly.
you can become an organ donor. Good.
And I am.
Good. I am too. It's on my driver's license.
Definitely.
Very good. Dr. Valerie Dye, nephrologist, thank you for being on the show, Val.
Thank you for having me.
Our pleasure. Good. Chronic kidney disease is caused mainly by diabetes and high blood pressure. Today, over 30 million people in the U.S. suffer from this disease. Dialysis treatment costs Medicare almost $100,000 per patient per year, which is staggering. It's important for you to be aware of the warning signs. Ignore them, and you may not live to become a kidney transplant recipient. If you are African American, you are 2 to 4 times more likely to develop chronic kidney disease than whites. So, if you think you may be at risk, see a healthcare provider right away. This is Dr. Lonnie Joe. I'll see you next time on Primary Care.
Primary Care was produced with the participation of the Detroit Medical Society, representing the work of physicians, the care of patients, and the health of our community.